All right. Hello, everyone. Welcome back to a Rafael Medina subspecialty episode. My name is Maddie, and I'll be facilitating the session today. So the focus of the session today is hepatology, and we have two fantastic clinicians from UCLA today who we are going to learn from. We have Dr. Arpan Patel, who will be our case discussant, and Dr. Christopher Coe, who will be the case presenter. So really excited to have you both here, and I'm actually going to pass the mic to them to introduce each other and maybe share any experience that they had together, anything they want to say about the other person. So maybe I'll pass the mic to you first, Christopher, and would love for you to introduce Dr. Patel.
Great. Hi, everyone. Thanks so much for inviting me to VMR. I've been looking forward to this and excited about it. I'm particularly excited about doing this with Dr. Patel. Dr. Patel is an assistant clinical professor of medicine at UCLA, where I'm doing my GI fellowship. And I love working with Dr. Patel. I first met him in my first year of GI fellowship. We have multiple liver clinics at the VA that he is in charge of. And some of the things that I've loved about Dr. Patel is not only does he teach you about the liver, how to work up a liver patient as a GI fellow, but he's also very interested in communication, in sort of critical illness communication. And so I've learned a lot about how to take care of the whole patient with end-stage liver disease from Dr. Patel. I always look forward to our liver clinics together, and I've been looking forward to this VMR.
Thank you, Chris. Well, I would
Yeah.
like this opportunity to introduce you too. So Chris is a third-year GI fellow. He's actually our chief fellow as well, which I'm really proud of. And he's going to be doing his transplant hepatology fellowship and leaving us sadly to go to Washington, D.C. But we're really excited for him and his future. One thing about Chris that I'd like to share is the fact that actually first year fellowship, he told me very often how distressed he was about the fact that we don't treat patients with alcohol use disorder in many of our treatment settings. And then it went all the way towards his third year right now, where he actually developed a curriculum for GI fellows to address alcohol use disorder and encourage them to perform motivational interviewing. So I'm just really excited about all the progress he's made over the past few years and really promoting culture change for our GI fellowship, but as including our attending. So thank you, Chris. And I'm also looking forward to this VMR with you.
Thanks, Dr. Patel.
Amazing. Well, we're both very lucky to learn from you both. And before we jump into the case, I'd love to hear just from each of you briefly what drew you to the field of hepatology and why you love it.
You want to start, Chris?
Sure. I think, coming into GI fellowship, I knew I liked GI. I knew I liked hepatology, but wasn't sure that that's sort of what I wanted to do for the rest of my life. But I think it was honestly lots of experiences in fellowship, and a lot of those experiences actually had to do with seeing how Dr. Patel worked with patients and seeing sort of, I guess, what was possible with a hepatologist. So I really think that a lot of my interests, I think, in seeing how as a transplant hepatologist, you can really, as I mentioned before, care for the entire patient and both the medical complexities and some of the psychosocial complexities involved in that. And I think Dr. Patel's mentorship and helping me to develop those interests really made me realize that I'm going to be very happy as a future transplant hepatologist.
Oh, that's very nice of you, Chris. I actually knew I wanted to do liver disease, interestingly, since med school. I always found I'm very much like an internal medicine type of guy, so I always find like treating all parts of the body like as the most important, and liver disease pretty much affects everything, which got me initially interested. But I found, in addition to just the complexity of liver disease, I was equally interested in just how complex the patients are from a psychosocial standpoint. And really, they represent the most vulnerable people, I think, that we treat in medicine. So just being able to kind of combine some of that clinical interest, interest in science and interest in psychosocial medicine, I think made hepatology a perfect fit for me. And you'll kind of know when you go to professional societies where you find your people, and hepatologists are definitely my people. So I think we have both in that we have very similar journeys to hepatology.
Fantastic. Thank you both so much. Well, I think we're all really interested in the learning from the case. So we'll get started. So Christopher, whenever you're ready, we'd love to hear the first aliquot.
Sure. Let me pull my screen back up here. Okay. So Dr. Patel, you ready for the first aliquot?
So,
All right. This is a 33-year-old woman who you're seeing in your hepatology clinic. She recently moved here from Europe, and she's coming in. She says, the doctor I saw before I immigrated here said that I had to see a liver specialist. She's a refugee. She doesn't have any records, but she says she's been generally healthy, apart from being overweight, until last year when she started noticing worsening fatigue. She tells you that she's been struggling with depression that's worsened in the past few years. And she says that before moving here, she saw a doctor in Poland who ordered an ultrasound after performing a physical exam. And on the ultrasound, they saw what she says was a large spleen, so you should see a liver specialist. And that's why she's coming to you in clinic. Not a lot to go on initially, but this is what I had. So I'm curious to hear what you think, Dr. Patel.
yeah. So should I just go and give you a little bit of thoughts about this?
Yeah, and Dr. Patel, I think this is, as you said, a very interesting start. Would love to hear any of your thoughts, but specifically, how do you think about splenomegaly and how would you link this to potential liver disease?
Yeah, I think that's great to start off with. So splenomegaly can happen in a lot of different reasons. And I think the way that I typically think of it is you have processes that cause increased platelet consumption, as well as processes that can cause increased pressure on the spleen from the circulation. And two things that immediately come to mind that can contribute to both increased pressure on the spleen as well as decreased platelet synthesis are splenomegaly related to portal hypertension. And so portal hypertension itself can manifest from many different things. We like to think of cirrhosis of the liver as the major cause of portal hypertension, but you can also get portal hypertension from prehepatic causes like portal vein thrombosis, from intrahepatic causes like cirrhosis and infiltrative disorders, as well as post-hepatic causes like bradycardia and heart failure. So immediately when I think of splenomegaly, I'm thinking of portal hypertension as a major cause. But in addition to portal hypertension, I do also in my mind, I'm starting to think about other reasons why a person might have an increased spleen, and that can be from a number of hematologic conditions as well that can contribute to the spleen having to work in overdrive. So the typical two things I like to think of in general for splenomegaly are those two things. I have other thoughts about this case in particular if you wanted me to continue, Mata.
Yeah, would love to hear other thoughts that you have at this point.
Yeah, so I sometimes find it interesting when we get referred to these patients because someone, I think it's interesting that this patient was referred to a hepatologist because of an increased spleen, but clearly they were thinking of liver-related etiology. So assuming that some of what's going on is liver-related, the fatigue actually really jumps out to me. Fatigue can be caused by cirrhosis in and of itself, but it can be also caused by a number of other conditions. So some things like viral hepatitis come to mind, but also conditions like primary biliary cholangitis. Sometimes we like to think of primary biliary cholangitis as having symptoms like pruritus, cholestatic type symptoms as the presenting factor, but actually fatigue is really common. So in this young 33-year-old woman who has splenomegaly and fatigue, I'm typically thinking of something chronic, something like primary biliary cholangitis. Other things that I'm also thinking about in a young person with fatigue and a large spleen, if it's an acute etiology, could be things like Epstein-Barr virus causing mononucleosis. So a lot of this has to do with kind of the timing. It seems like this has been happening over the past year, but if the time frames were more acute, I would be thinking about something more infectious like mononucleosis.
Fantastic discussion so far, Dr. Patel. All right, Christopher, back to you for the second aliquot.
All right. So you take some additional history, and because you're a good GI fellow, you take a focused GI history. She has no nausea, no vomiting, no melena, no hematochezia. There's no abdominal distension, edema, or confusion. She has no history of jaundice or previous icteric illness. She says never in her life. And she does not have significant pruritus. On careful review of systems, apart from the fatigue that I mentioned and the history of obesity, she does note some worsening depression. It had been well managed on sertraline until recently. She doesn't have suicide ideation or any vegetative symptoms, and she gives her mood as okay. She just notes that it's been worsening. She attributes this to turmoil in her home country of late. She's never had surgery before in terms of past medical history, but you notice that she's there with her husband, and you ask, and they do not have children. She would like to have children, and they've actually been trying to conceive for the past 18 months unsuccessfully. You dig into her family history a little bit. There's no family history of GI disease, inflammatory GI disease, malignant GI disease, and there's no family history of liver problems that she knows of as well. She does say that her sister had leukemia. She says that her mom and dad both struggled with being overweight. They're both obese, and her dad also has hypertension. Her mom also has high cholesterol and had a history of breast cancer as well. In terms of her social history, she worked as a secretary in a mechanic's office in Eastern Europe for most of her life. Some turmoil in her home country led her to leave and migrate to the US after spending a year in a neighboring European country. She drinks 3 to 4 glasses of wine a week. She's married, does not have children, but would like to have some, as I mentioned. She takes sertraline 50 milligrams daily. She's been on that for a decade. She has no known drug allergies. I can pause to let you guys catch up, and then I can go ahead and get into the physical exam here. For vitals, she has a blood pressure of 101 over 64. Her heart rate is 73. Her SATs are 98% on room air. She weighs 198 pounds, putting her BMI at 30.1. She is accompanied by her husband. She's in no acute distress. She looks well. There's no conjunctival icterus. The eyes appear normal to you. She's a little bit anxious, but otherwise her psychiatric exam is unremarkable with normal affect. She's alert and oriented ×4. Since you're in hepatology clinic, you check for asterixis. You don't see any, but you do notice when she stretches her hands out, she has the finest of tremors, of postural tremors. She says, I'm just nervous. She has no jaundice, no spider angiomata, and no palmar erythema, but you do notice some washed out nails where you can't really differentiate between the lunula and the rest of the nail. And some of her nails have this thin brown band at the end. On abdominal exam, you notice central adiposity and obesity. There's no fluid wave. You can't palpate a liver edge, but you do notice some left upper quadrant fullness to deep palpation. You auscultate the liver and you don't hear hepatic bruit. Her pulmonary exam and cardiovascular exams are unremarkable. And on a global musculoskeletal assessment, you don't see sarcopenia or temporal wasting. She doesn't have any pitting edema on her extremities either. All right, that's your second aliquot.
Yeah, so we've gotten quite a lot of really interesting information from Christopher, and Dr. Patel would love to hear both your general thoughts, but also really focusing on the physical exam. What stands out to you, and what do you look for in a patient where you're concerned about potential liver disease?
Yeah, these are really great points. And let's focus on the physical exam first. So, when it comes to patients with liver disease, I do typically look for signs and symptoms related to cirrhosis. And so as Christopher described, looking for palmar erythema as well as telangiectasias. These can actually be somewhat difficult to find. I mean, palmar erythema is actually not common in most patients with cirrhosis, but it's a very specific finding. Things like telangiectasias, I typically look for around the chest area. And if patients with more with darker skin, I think you have to be a little bit more cautious about making sure you do a really thorough exam. As Christopher mentioned, I do also look for asterixis and look for signs in the nails. And I do find an interesting conclusion from the washed out nails and thin brown end of the nails. That does remind me of something called Terry's nails, which is when you have loss of the lunula. And that can be present in cirrhosis, and it can also be present in certain metabolic syndromes. But Terry's nails is a clue in this case. Given kind of what's being described. In addition to the things that I mentioned, some complications of portal hypertension are more obvious on exam, such as ascites. And those things as well as conjunctival icterus, so those things I'll look for pretty consistently. But in this patient, what sort of stands out to me are the nails.
Yeah, and a few questions that I had. So from the first aliquot, you were saying that one way to connect splenomegaly and liver disease is through portal hypertension. And I'm curious if you could comment on whether or not you see other signs of portal hypertension here or not.
Not directly. I think some things I look for, I would probably confirm that she has an enlarged spleen on exam. I would also potentially feel the liver, although it could be really difficult to feel in patients who are obese, the surface edge. So nothing jumps out to me in terms of signs and symptoms of portal hypertension, but with regards to cirrhosis, what jumps out to me is the washed out nails, because that could be a sign of Terry's nails. And sometimes that might be all that you find on exam. So yeah, I think that the Terry's nails I am anchoring on a little bit. I don't find anything on this exam concerning otherwise for portal hypertension.
And I'm not sure if I'm really curious about Terry's nails. Is there an explanation for why Terry's nails comes up in cirrhosis? I'm curious if there's kind of an underlying pathophysiologic explanation or if it's just an association.
I think it's just an association. On the top of my head, I would think it might have to do with loss of protein synthesis, from cirrhosis, because it is more described in people who have more worsening liver failure than just compensated cirrhosis alone. But I haven't found to nail that pathophysiologic association.
Fantastic. And then one last question before the next aliquot. So Christopher mentioned that there was not the presence of asterixis, but for my learning and for people listening to this, what is the best way to check for asterixis?
Oh yeah, that's a great question. So I actually go through this sequence with my patients, as well as try to do this with my caregivers too for the patient. So what I ask them to do is put their hands out as far as they can, straight, like they're stopping traffic. I say those words. And then I usually ask them to also close their eyes a little bit so they're less focused on it. And then once they do those things, what you'll find is like a small beat going downwards like this. Sometimes it's not necessarily symmetric that they're doing it at the same time. But when you notice that beat, that is asterixis. And it can be pretty subtle, but once you see, once you've seen it in the hospital, once you've seen it in clinic, it's pretty recognizable. I will say that I have to be cautious when I interpret asterixis in two different cases. So for asterixis, you also want to make sure that patient doesn't have other reasons for toxic metabolic encephalopathy, particularly uremia. They have kidney failure. Uremia can also cause asterixis. The other thing is when patients, particularly in the ICU, are not able to move their limbs. I learned this actually during my training. And one thing you can ask them to do is perform the milkmaid sign. And this I haven't actually ever seen published, but it's basically what you do is you grab, you put your hands around them. You ask the patient to grab your hand because they can't put their hands completely outright. And if they let go of your hand, that might be a sign of asterixis too. So I use asterixis. I do what I mentioned for an asterixis exam, and if I'm unable to do it, I use what's called a milkmaid sign.
Fantastic. And then lastly, before moving on to the next aliquot, how are you thinking about the differential right now in this patient?
Yeah, I mean, I am anchoring on a few things, given, especially particularly some of the things that are highlighted. the fact that the patient didn't have a strong autoimmune history or liver history is important. What I'm finding many details of in the history are aspects of metabolic syndrome, as well as increased alcohol use. So these things are still pointing me towards, with regards to liver-related issues, pointing me towards a diagnosis of MASLD. So just to step back for a second, the nomenclature has changed from NAFLD or fatty liver to this larger entity called MASLD, which is metabolic dysfunction associated steatotic liver disease. And so actually what I'm thinking is happening in this patient might be a combination of metabolic dysfunction associated steatotic liver disease and alcohol associated steatotic liver disease. And so this has actually been redescribed, and I'm thinking that this patient might actually have potentially steatotic liver disease from both alcohol and non-alcohol causes contributing to her case, and with or without cirrhosis. So that's actually the leading concern I have for this patient. Of course, again, considering other causes of portal hypertension still with the enlarged spleen is important. Again, considering that if the fatigue has actually been more recent, I'm still thinking about something infectious, but nothing really stood out on the physical exam. So that's kind of where my mind is right now.
All right, fantastic. Thank you. Christopher, back to you.
All right. So third aliquot, we'll go through some initial basic labs and basic imaging. So you review the basic metabolic panel. Her sodium is 134. Her potassium is 3.9. Her creatinine is 0.57 with a BUN of 15, and her glucose is 95. Her white blood cell count is 4.8, hemoglobin of 11.7, and platelets of 68. And I know Dr. Patel's been waiting for the liver tests. So she has an AST of 75. The upper limit of normal on this lab is 62. An ALT of 65 with an upper limit of normal of 70. An alkaline phosphatase of 71 with an upper limit of normal of 113. And a total bilirubin of 0.6. At this point, you review her abdominal ultrasound, and the radiologist reports that there's a heterogeneous echo texture compatible with steatosis, a nodular liver contour, a moderately enlarged spleen, a liver length of about 15.2 centimeters, and no appreciable ascites. You check some additional, no, you don't yet. You wait for the fourth aliquot. So we'll stop there.
Thank you so much, Christopher. Dr. Patel, what stands out to you about this lab and the abdominal ultrasound?
Yes, so a lot of things. Actually, one thing I wanted to ask is if we had the albumin for the patient and the MCV. Those are the only two things.
Sure. The MCV is 95.
Okay.
And the albumin is 3.3.
Okay. So a few things jump out to me.
And
so,
I will just correct one thing on the,
yeah.
I'm sorry, on the sheet. The BMI is 30.1, not 40.1. Not that it makes a huge difference, but.
Yeah. Yeah, no, a few things definitely jump out to me. So my head first goes to the nodular liver contour, which makes this concerning for cirrhosis, particularly with the splenomegaly. I think that when I see a nodular liver contour, I also have to pause a little bit because I think for most people that automatically means cirrhosis. For me, that doesn't. When I think of a nodular liver contour, I think of not just cirrhosis, but things like nodular regenerative hyperplasia. I also I think of congestive hepatopathy, which is when the liver gets congestion from heart failure. So I always have to pause when I see that, but I am starting to think more that this could be cirrhosis, particularly with the enlarged spleen. Some other things that are kind of pointing me towards cirrhosis is the fact that the patient has thrombocytopenia, which goes with much of what we've discussed with the enlarged spleen. But another mechanism of why platelet counts are low with cirrhosis is also because a low rate of thrombopoietin generation from a liver that's not working well. So the platelet count is starting to check out. I am noticing that the white blood cell count, hemoglobin, and platelet counts are all low. This could be for a lot of reasons. We can see there might be some etiology going on, that's completely separate, but that could also happen in patients who drink, who have a larger problematic alcohol use, that they can start to have pancytopenia. You can also get platelets that are low independently in patients who drink too. So that is starting to cross my mind. I'd probably expect an MCV that was a little bit higher in patients who had drinking, and potentially if a GGT was measured, that an increased GGT in those patients too. So it doesn't completely completely mean that that's all related to that, but certainly I'd like to work up the anemia in addition to all of the other things going on, but it could be unrelated. And the low albumin also makes me concerned that the patient has some reduced liver function. Altogether, this is painting a picture for me of a patient that has compensated cirrhosis with clinically significant portal hypertension potentially, given all that I'm seeing.
Thank you. One question I had is the abdominal ultrasound commented on steatosis, and I was wondering if you could, for kind of all the learners listening to this, like how do you define steatosis, and what is the differential for hepatic steatosis?
Yeah, that's great. So first thing I'll let you know is that the ultrasound often picks up steatosis, but it doesn't mean, just because the ultrasound does not have steatosis on it, doesn't mean that the patient doesn't actually have steatosis. So steatosis refers to fatty deposition in the liver. And the major categories that we think about that cause steatosis are related to metabolic dysfunction. So that's what was, termed NAFLD before. Now we call it MASLD. And that's related to metabolic syndrome. The way I like to explain it to patients is that for reasons that we don't completely understand, your metabolic syndrome, diabetes, high blood pressure, hypertension led to an increased deposition of fat in your liver. And that's causing problems. So that's how I describe NAFLD or MASLD to patients. Another cause of steatosis could be alcohol. So alcohol causes fat deposition in the liver with similar mechanisms to MASLD. And other things I look for are drug-related steatosis. So there are certain medications that are associated with steatosis. Some of them are a little bit more obvious, like things like the SERMs, as well, like such as tamoxifen, as well as corticosteroids can cause steatosis. Some of them are actually causes of microvascular steatosis, where you wouldn't see objective steatosis on imaging. So the classic one is Ray syndrome from aspirin uses, causes microvascular steatosis. So the general categories I typically think of are this metabolic dysfunction related, alcohol associated, and drug induced. And for the people who don't have any of those things, I do think of what's called, what was used to be called lean NAFLD, where you don't have any of the other risk factors, but still have steatosis.
Thank you. That was
Dr.
such
Patel?
a brilliant breakdown.
Dr. Patel, when you're seeing a patient like in a clinic like this, when do you worry that, we see alcohol and MASLD all the time? When do you start worrying that, maybe we need to think about something besides that?
Thinking about something besides NAFLD, you mean like just in a differential for people with cirrhosis?
Yeah, because I feel like a lot of times, even in liver clinic, we'll see that and we'll sort of stop. Like, oh, it's metabolic associated steatosis, or it's alcohol associated. When should we not stop, and when should we keep investigating?
Yeah, so just generally speaking, for all people with cirrhosis, regardless of if they have concerns for fat in the liver or any of those traditional risk factors, I send a viral hepatitis serologies on everyone. So I'll always get Hep B and hepatitis C serologies on everyone. The reason is you're always allowed to have more than one cause of liver disease. So, and I think that's a really good teaching point, because sometimes we do often stop, but we actually know that a very sizable portion of people with cirrhosis have more than one diagnosis. So when we anchor on one cause, what we do is we potentially are not getting ourselves to think about other causes. So I always check viral hepatitis. I always check iron studies for hereditary hemochromatosis. And then I usually base it on the history, because the problem is, particularly for conditions like autoimmune hepatitis, if you do send some of the workup, the other side is doing too much workup and then causing a false positive, which will lead to a lot of unnecessary workup. So for instance, for patients with MASLD, about 25% of people with MASLD will have a positive ANA. And that's part of the workup for autoimmune hepatitis. So I will often not send an ANA on all patients who have cirrhosis or transaminase elevation unless they have things in their history that are suggestive of autoimmune hepatitis, like a family history of autoimmune hepatitis, hypothyroidism, patients coming in who are quite young with liver disease of unknown etiology. So I typically tailor it to the history after making sure I get viral hepatitis serologies, BNC, and iron studies on the patients. If that answers your question.
It does. Thank you.
And one last question before the next aliquot. For the metabolic associated steatotic disease, I'm curious how that diagnosis is exactly made. Is it based off of history and then ruling out other causes, or could you talk a little bit about how you make that diagnosis?
Yeah, so metabolic dysfunction associated steatotic liver, metabolic MASLD is made by first having signs and symptoms of metabolic syndrome. So that is presence of diabetes or at least two out of at least four. So presence of diabetes or pre-diabetes, high blood pressure, having hyperlipidemia, and then weight. So if you have two of those four, then you're considered to have metabolic syndrome. And then if you have steatotic liver disease, it has to be made in a few different ways. So that can be from imaging showing steatosis or a fiber scan. But the thing that's interesting is that in clinical practice, sometimes you won't see that. So for instance, this patient, let's say this patient didn't have steatosis on their imaging, but had cirrhosis. By the time that some patients develop cirrhosis, they don't have any findings of fat anywhere. Like even if you do a fiber scan, you won't see fat. So sometimes you end up having a presumed diagnosis that this was related to NAFLD, but most of the time, MASLD, but most of the time you'll see some indication of fat either on imaging or a fiber scan. Does that answer your question, Maddie?
Yeah, it does, definitely. And as I was looking at the board, you mentioned kind of the nodular liver contour, which you said can be cirrhosis, but can be other things. It doesn't necessarily have to be cirrhosis. And then I'm looking back to the physical exam, and we're not seeing the signs of pulmonary erythema or telangiectasia. So I'm curious, like how you're putting that together, that you're having imaging that can maybe put a signal towards cirrhosis, but you're not seeing some of those other signs on the physical exam. Like, how are you thinking about that?
Yeah, and so this is a really great question. Really points to this understanding that cirrhosis is a clinical diagnosis, because we just can't do liver biopsies on everyone. And there ends up being things that are suggestive of cirrhosis with higher likelihood ratios. So some of those things end up being signs on physical exams, and things like Terry's nails, spider telangiectasias, and ascites have very high positive likelihood ratio. So Terry's nails points me in one direction towards cirrhosis. But for me, clinically, what I look for and what I see the most is I can typically make the diagnosis of cirrhosis when I have imaging findings like nodular liver, thrombocytopenia, platelet count less than 150, and an etiology. And in this person's case, I have those. And so I can make the diagnosis of cirrhosis pretty confidently. I think that in practice, when I make that diagnosis, the times that I'll walk away from that is if I'm really entertaining some other things in the differential. So something like congestive hepatopathy, but this patient has no, signs and symptoms of volume overload. And so I can typically make that diagnosis based on the imaging, the platelet count, and physical exam findings. But I don't think you need necessarily a physical exam finding in order to make that diagnosis in most cases. Which is an interesting teaching point, because I don't know if we go over that a lot. There tends to be a lot of everyone's kind of looking for something on exam that'll point you to that, but many patients, particularly in early phases of cirrhosis, who don't have decompensation yet, who might be at this woman's stage, who's relatively young and who just has some clinically significant portal hypertension that you can't see on exam, you might be hesitant to make that diagnosis. But in this case, I would actually probably favor making that diagnosis.
Thank you so much. All right, Christopher, back to you.
All right. On to aliquot number 4. So we have some additional labs. We also note a normal GGT, an INR of 1.3. HCV antibody is negative. Hepatitis B surface antigen, surface antibody, and core antibody are negative. Hepatitis A, IgM, and IgG are negative. Serologies for EBV and CMV are negative. The ferritin is 68. The iron saturation is 28%. The A1AT alpha-1 antitrypsin genotype is, or phenotype is NN. The ceruloplasmin is 4. The lower limit of normal on our lab is 14. The serum copper is 61.8. The range is 80 to 155. ANA is negative. Anti-smooth muscle antibody is negative. Antimitochondrial antibody is negative. And the total IgG is 105.
Perfect. So great place to pause here, and would love to hear any thoughts that are coming to your mind, Dr. Patel, and specifically, we're from the last quote, we were thinking this patient has cirrhosis. How are you thinking of the potential etiology for that at this time?
Yeah, I think that these are really helpful serologies to send. I would send them in every patient. Things that are coming to mind for me is that this patient clearly is negative for all viral hepatitides. I think the one thing I will note that just did come to mind when thinking about where this patient is from, particularly Europe, is ensuring that they, in some cases, I do actually check for hepatitis E, because she could be coming from an endemic area, which could be another cause separately of chronic liver disease. So in that case, the reason why we don't check it often is because we don't have really a treatment for it. We usually just monitor patients for it, but the way where she is from geographically can make me think that she might have some acceleration due to hepatitis E. So I might consider checking it. But she is negative for B and C. She's negative for any of these viruses, such as EBV, that could be causing her more of a mononucleosis picture. Her ferritin is low, but her transferrin saturation is actually about normal. Yet, she might be developing some early iron deficiency anemia, which makes me think of potentially doing a workup from that, which could be completely independent again from her liver. Of course, we are always so focused on ceruloplasmin, it being low. This is a common thing that's checked for Wilson's disease. And we often see a low ceruloplasmin in patients who have chronic liver disease. And then the question is, are we really how worried are we to do a complete workup for Wilson's disease in these patients? And often, this ends up being a common issue we deal with when considering all these conditions. And can we potentially put some of this workup? Can we consider some of this workup in this young person? Well, the fact is that she is young and she does have a fine postural tremor on exam. In Wilson's disease, we are usually thinking of involvement of the basal ganglia. So, thinking if she had more like choreiform movements, or if she had other, findings other than the postural tremor, I'd definitely be more concerned. But if, again, if we were to just stop here and say this was alcohol and fatty liver, that is fine. But I might consider also just completing a workup on that. And what I would usually consider is also doing a urine copper assessment, seeing how high that urine copper would be. And if we're really at this stage, what I would consider doing is initiating some lifestyle modifications for her underlying liver disease while continuing a workup. And if things don't get better, I would be more aggressive in aspects related to the Wilson's disease workup. But I think the caution is that when you have people with cirrhosis with a low ceruloplasmin, you can see that in people with just chronic liver disease. The IgG itself is kind of like is normal. It's not at a stage where I would be really concerned about autoimmune hepatitis. But so at this point, what's only changed my mind is maybe potentially doing some more of a workup for Wilson's disease, but understanding that it wouldn't prevent me from starting to counsel this patient on weight loss and reducing her alcohol intake.
Yeah, thank you. One question I had was actually going back to I believe Christopher talked about the alpha-1 antitrypsin genotype, and that's something personally for me, I'm not super familiar with what the MM refers to. Could you comment a little bit on that?
Yeah, so there are a few alpha-1 antitrypsin phenotypes and genotypes that we typically send. The varieties we see are usually related to MM and MZ and ZZ phenotypes. So, the important thing about alpha-1 antitrypsin is that it causes cirrhosis, but it also can cause early emphysema in patients. And, the type that we typically see that's most clinically significant is the ZZ phenotype when those are people are at risk of developing liver disease. So, in general, when I send those phenotypes, the really one that I'm looking for that can be related to liver disease is the ZZ phenotype.
Thank you. And you comment on this a little bit, but how would you move forward with managing this patient?
Yeah, I think that I still am not completely sold that this person has Wilson's disease, but what I would do, just to be thorough, the way that it typically works in the spectrum of working this patient up more is doing a urine copper level and probably sending them to ophthalmology to assess for Kaiser-Fleischer rings. Because the thing is that Kaiser-Fleischer rings are pathognomonic for Wilson's disease. So to be judicious about, to be cautious about her care in this young woman, I would probably do that. And I would send a urine copper level. If the Kaiser-Fleischer ring assessment ends up being negative and the urine copper level remains high, I would consider doing a liver biopsy on this patient just to be totally sure, and sending that for copper levels to see if they're elevated. I don't think it will stop me from trying to institute some counseling for reduction in alcohol use and weight loss. Typically, how I counsel these patients who have what looks like advanced fibrosis, F3 or F4, is recommend at least a 10% weight loss for them from their highest weight. So if we assume, for instance, that this patient had about 200 pounds as their highest weight, and we're not sure if that's the case, counseling them to try to reduce it to 180 pounds is what we typically do in clinical practice. I find that getting initial fiber scan on these patients, if you have access to them, is really helpful. Even though there aren't really specific recommendations to get fiber scans on people who you think have cirrhosis, I find it helpful for two reasons. So it can provide some patients the level of detail they need in terms of understanding how much their liver has been affected by scar tissue and fat. And that quantitative assessment could be really helpful for people who are making some of those behavior changes, because when we repeat them and see an improvement, it actually feels like it's something that they can target. So I do get a fiber scan on these patients at baseline. The other helpful way that I think of using a fiber scan is actually regarding decision-making for endoscopy. So you might, if you had a board question on if every patient with cirrhosis should get an endoscopy, you would say yes. But in clinical practice, we're actually being a lot more judicious around individuals and who actually needs them, who actually needs an EGD. Because not all patients have clinically significant portal hypertension that merits it. And so what I apply is a criteria called the Bovino 6 criteria. And what that states is that if a person has, on their fiber scan, has a kilopascal level over 20, under 20, or a platelet count over 150, those people should be excluded from getting an endoscopy. Because this patient has a platelet count under 150, that's pushing me towards doing an endoscopy for them, but I would probably consider doing a fiber scan. If I saw a kilopascal level over 20, that would push me towards doing an endoscopy for them. So I guess to sum everything up, I would consider counseling, completing the workup for Wilson's disease, and getting a baseline fiber scan for this patient. And probably serial imaging for HCC surveillance and alpha-fetoprotein level.
Amazing discussion. Thank you. Christopher, what happened next with this patient?
Yeah, so that's great. So we had a very, very similar discussion when I was presenting this patient to my attending in liver clinic. And we said, she drinks, She's overweight. She needs to work on that. But given her age, we wanted to be thorough. So just as Dr. Patel said he would do, in addition to having her cut back on alcohol and lose some weight, we did check a 24-hour urinary copper, and it was 81 micrograms per day. The upper limit of normal there being 35, so that was elevated. We calculated a non-ceruloplasmin-bound copper that was 49.2, and that's also above the upper limit of normal. Because of these findings, we actually proceeded with a liver biopsy in her. She had some mild cholestasis with non-specific portal chronic inflammation, some mild steatosis, and a trichrome stain highlighting mild portal fibrosis, and a rhodamine stain, which highlighted red-brown granules throughout the liver parenchyma. They actually were able to calculate a copper dry weight of the liver, and it was 894 micrograms of copper per gram of hepatic dry weight, and the normal value for that is less than 50. So we started copper chelation therapy, and her fatigue improved. She was able to conceive. She had a healthy baby boy, and we continued to see her with frequent monitoring, and she ended up doing really well. She was, to Dr. Patel's point, sent to ophthalmology, and actually before we got the 24-hour urinary result, her Kaiser-Fleischer rings were negative. And this was the first patient with Wilson's that I saw, so I almost was like, oh, we should just cancel the 24-hour urinary copper. But as I'm sure Dr. Patel can tell us, that you do not need to have Kaiser-Fleischer rings to have Wilson disease. So don't think that just because you have a normal ophthalmologic exam that you don't have Wilson disease. It's a big learning point for me.
Yeah, wow. Thank you so much, Christopher, for sharing kind of what happened with this patient. Dr. Patel, I'm curious kind of what reflections you have and how this kind of relates to other presentations you may have seen of Wilson's disease.
I mean, this is why I love hepatology, right? You know, you get so surprised from some of these findings, but the truth is that, you know, even particular with the ceruloplasmin being low, we often get fooled. You know, there's a lot of times we get stuck into tunnel vision, but I think the truth is that we, as hepatology, come in many ways far in terms of realizing that we shouldn't biopsy everyone, you know, when it comes to finding out an etiology. But if you have sufficient reason to think that there's something else going on, you do have to proceed to doing it. And we have the ability to do that workup, and we have very effective treatments. So trientine for Wilson's disease, particularly chelating agents, are incredibly, you know, effective, and hardly ever require you to have a retransplant, to ever go to transplant if detected early. So I think this is an incredible win for this young woman who had a persistent workup despite having reasons other than alcohol and mast to cause her liver disease. But I will say, you know, she is already at cirrhosis, and that could have been contributed by the fact that she had many different conditions going on at the same times that were contributing to her liver disease. So I think that what I tell people is that this person has Wilson's disease, but she also does have alcohol-associated liver disease potentially, as well as mast. So she has all three, and we fixed one of them, but that doesn't give that means that we still have to monitor her to make sure her other metabolic risk factors are being controlled. So I'm really happy that this woman had an outcome and was able to have a child. And I'm hoping that she continues to not have progression of her portal hypertension. And I think this is a really wonderful case, Christopher. And I think that outlines a lot of things I see actually happen in clinic all the time. So I'm glad you chose it to present.
Oh, thanks, Dr. Patel. Yeah, I just feel like it touched on a lot of different aspects of hepatology. So I'm glad you enjoyed it.
Yeah, and another question is, could you talk a bit on how kind of the role that genetic testing plays in making the diagnosis of Wilson's disease?
Yeah, you could send genetic testing for these patients. It's a little bit different. It's more of a rule out test when you send genetic testing. To be honest, most of the time, many of us will just go straight to the biopsy, because there are sort of suggestive criteria of sending the mutation analysis if a person really doesn't have, if the person really doesn't have, I think that would usually be the case if the biopsy ended up being negative, but you still had a concern, they didn't have enough iron chelation. So we do the mutation analysis, I think, if people didn't have sufficient copper deposition in their liver at that point.
Got it. And another thing I was thinking about throughout this case, so the woman, she talked about how she was having difficulties conceiving. Is that in your mind related to her liver disease? Or unrelated?
Yeah, there actually recently was a review on pregnancy and cirrhosis, and that was published. And I believe that there may have been a slightly higher risk of complications related to pregnancy, but I don't necessarily think that they found that there was a higher rate of miscarriages or more of a difficulty related to conceiving. I do think that the practice is now for us that if we do have women who are pregnant, we do send them to maternal fetal medicine, pretty much always, just for co-management. But I haven't necessarily heard of an association between cirrhosis in particular or Wilson's disease and difficulty with pregnancy.
Thank you so much, Dr. Patel. Well, Christopher, I want to turn it over to you before we ask Dr. Patel to summarize some key learning points that he wanted to highlight. But Christopher, any reflections you want to share on taking care of this patient and what it was like?
I mean, it was a wonderful sort of happy ending, if you will. We sort of considered whether or not to go ahead and do this invasive test, the liver biopsy. She was anxious about it, but we ended up doing it, getting a diagnosis, and having it be an actionable diagnosis. And I think, I don't know whether the improvement in her fatigue, the birth of her child was related to the fact that she quit drinking, lost some weight, or reduced copper loading. But regardless, it was a really nice outcome, and it was sort of a feel-good situation. I saw her like a year later, and she came with her baby, and it was really, really nice. I think for me, one of the other points that stuck out to me when I was reviewing this case and preparing for this VMR was this idea that we see these very common steatosis, hepatic steatosis. Patients get referred to us all the time. And given the demographics, many patients with steatosis, they're going to have alcohol use, they're going to have fatty liver, but it almost sort of made me anxious about, gosh, like, how far do we need to go on each and every patient we'd see with fatty liver disease? And the answer is obviously not to check 24-hour urinary copper on everyone. That's not right. It's not right to biopsy everyone, but I think sort of trusting your gut a little bit and sort of developing that clinical intuition when you say, okay, it's the 33-year-old lady, her depression has recently gotten worse. She has this strange tremor that's not asterixis, but it's not quite right. She has cirrhosis already. Am I really confident just saying, like, lose weight, stop drinking, or do we need to go further? And I think sort of trusting that gut instinct is what led us to order these additional tests and push for the liver biopsy. I also think it's interesting to point out that in my reading, at least, even patients who are lean, who don't have an alcohol history, and Wilson disease can present with a steatotic appearing ultrasound. So that's not to say that everyone with a fatty liver on ultrasound should be worked up for Wilson disease, but it can be an early presentation of the disease as well. I think in this case, it was probably due to her drinking and weight, but that's just an interesting teaching point.
Yeah, beautiful reflection. Thank you so much for sharing this case with us, Christopher. And Dr. Patel, we'll turn it over to you. And if you could summarize, 3 key learning points that you want people listening to this to take away.
Sure. I think, again, this was a fantastic opportunity to kind of share something that I see, a type of thought process that I have very commonly in clinic. Some of the teaching points I think I would take away from this is understanding the clinical diagnosis of cirrhosis, and that you might not see some of the classic physical exam findings like angiectasias or ascites, but may have to find things on exam that are more subtle, such as Terry's nails, but have to rely on other aspects of the clinical diagnosis, which include the imaging findings and the thrombocytopenia. So I think that understanding that you may not find things on physical exam, but still might have cirrhosis is important. And in this woman, the fact that she already had clinically significant portal hypertension as a young individual. So really relying on that clinical assessment is really important to establish the diagnosis of cirrhosis. The second is understanding, I think, as Chris pointed out, that people can have multiple etiologies of liver disease. So when you stop at one, you really should make sure that you're at least ruling out the most common things. And then in this woman's case, the fact that she was young made us pursue more of a workup, which was very appropriate. And the third thing is, and maybe this is something that I'm sort of thinking about, just reflecting on just in my capacity as a hepatologist, but have a really good follow-up for these patients. Like, I think people can approach this situation many different ways, like a trial of weight loss, trial of reducing alcohol, and then considering more of a workup. But so much of what we do in hepatology is being able to ensure that we're having subsequent and constant follow-up with these patients to make sure that we're addressing all of those things and building a relationship with them. And I think I can imagine that just with the way that Christopher and this physician sort of approached the patients, that they established a really great commitment to their care, and were very committed to making sure they understood what was happening to the liver. And so I think, if for those of you who are interested in hepatology or considering it, know that we form really close relationships with our patients, and these are the types of cases we see that are very fulfilling, in which we're able to understand so much of their lives and then make sure that we're addressing all of their causes of liver disease and ensuring that they have a good outcome if possible.
Yeah, thank you so much. Really, those are fantastic teaching points. And I'm just reflecting on the journey. We started with like a 33-year-old woman with a report of a large spleen and ended up with Wilson's disease and potentially a few other diagnoses. So it's I learned so much in this past hour, and I really appreciate both of you and Christopher for preparing, really thoughtfully preparing this case. So thank you so much to you both.
Thanks so much.
All right. Well, thank you to Noah, who did these teaching points. We won't have him summarize them out loud, but I just want to highlight that like half of the board is there of teaching points. So thank you so much, Noah. But we will end the session here, and I hope you all have a great rest of your day.
Thank you again.
Thanks, everyone.
Bye, everyone.
Thanks for inviting me.
Thank you, guys.